what is worthwhile for us and for patients, and to trade off, like how much toxicity do we spare, but what's the trade-off in terms of the risk of recurrence, and which difference is acceptable? And that is really a very important question to ask. Next slide. Let me back step a little bit and talk about, what we really do with adjuvant therapy from stage 3 colon cancer. This is now from Jeff Eierhardt's presentation from Dana-Farber, who discussed some of the abstracts that had the duration question in place. So when we look at 100 patients with stage 3 colon cancer, next slide, 60 of them are already cured with surgery alone. So they would never need treatment in the first place. So any side effects that we inflict on these patients is not necessary. One click, can you click one more? So these patients really didn't need chemotherapy in the first place. Now, unfortunately, we don't know who these patients are. Next slide. So when you talk about patients still recur, even if they have adjuvant therapy, so there is about 28% of patients, 25% of patients that will have recurrence, tumor coming back despite surgery and chemotherapy. And again, we don't know who these patients are. Next click. These patients, when you click one more time, these patients, chemotherapy didn't help, at least not enough. Next slide. When you now look at what chemotherapy can do, adjuvant chemotherapy, the treatment right now is compromised of 2 different agents, the so-called fluoropyrimidine, which can be the IV 5-FU, or the oral agent capecitabine or Xeloda. The most important component here, which helps us save patients' lives, is likely this fluoropyrimidine, 5-FU or capecitabine, where we save 15 out of these 100 patients. Next click. And when we add oxaliplatin to that, we add another about 8 patients to that. But it's very clear that about 2/3 of the benefit really comes from the 5-FU or capecitabine component, and only 1/3 from the benefit of adjuvant therapy comes from oxaliplatin. Next click. So these are the colored ones are the ones that benefit from chemotherapy as measured by cure. So next click. Next slide. So the question is really now, since everyone gets treated and a lot of patients unnecessarily or in vain and only few benefit, but everyone gets the side effects, is it worthwhile to reduce the numbers of cycles of treatment and then look at the same whether we have the same outcome or not? Next slide. So this is really what we were testing. So there was a randomization, meaning a flip of the coin, whether patients were receiving 3 months of treatment or 6 months of treatment. 12,834 patients were enrolled. And based on the studies, individual studies, this is a compiled analysis of 6 concurrently run studies. Patients could be receiving either FOLFOX or CAPOX. So FOLFOX is the regimen which is very commonly used in the United States, which uses where you need a port placement and you need a pump, and it's every 2-week treatment, and patients carry the pump at home for 2 days, and it's 12 cycles make up the 24 weeks. So for FOLFOX, the question was 6 cycles or 12 cycles. CAPOX is a different regimen. It does not necessarily require the placement of a port, so no surgery to put a port in. It substitutes the 5-FU by using capecitabine, which is an oral agent, and it's scheduled every 3 weeks. So it's 4 IVs if you look at a 3 months treatment for 12 weeks. And it's these capecitabine or Xeloda pills are given twice a day, 2 weeks on, 1 week off. So that's a different type of regimen. So we will see an analysis between FOLFOX and CAPOX, but there was no randomization. Patients were not kind of put in one or the other treatment regimen with a flip of a coin. So there is potentially some bias which patient received which treatment. And so take any comparison between FOLFOX and CAPOX with a grain of salt. Now, in statistical terms, just as those of you who like to dive a little bit more into statistics, this whole study had a non-inferiority design, meaning we wanted to make sure that we're not having a detriment that is unacceptable when we shorten the duration of therapy, detriment in terms of preventing, not enough preventing tumor recurrence. And statistical terms look at hazard ratios and the upper limit of the confidence intervals, and all this is complicated, but you should make note of the number on the right bottom side of the right bottom corner, 1.12. The study would have been positive for the overall patient population if this upper limit was not higher than 1.12, and I'll come back to that in a second. The next slide. So one thing that we try to show is that shorter duration is a source of toxicity, and that's clearly true. As you can see here, neurotoxicity, the nerve damage, 3 months on versus 6 months on, this is just on therapy, and you can see that patients who received a shorter duration of treatment, whether it's with FOLFOX or KPOX, had much less neurotoxicity. And this is, of course, something that we really expected, number one. Number two, wanted to demonstrate as a rationale why we wanted to investigate 3 months of treatment. Now, next slide is very interesting because the Scott study, one of these many studies, these 6 studies that we had, followed their patients with questionnaire, neurotoxicity, nerve damage questionnaires over time, including up to 5 years out, which is something data that we haven't really seen that much. And you can see in these bars, the higher the bar, the more to the top these bars were compared to lower, the more neurotoxicity was reported. And 3 months is in blue, and 6 months through treatment duration is in green. And even after 5 years, patients who had shorter duration of treatment still had better outcomes in terms of nerve damage compared to the longer duration of therapy. So this is something that I mentioned earlier. This doesn't really just go away. It's one of the side effects that I'm very concerned about, because a lot of our treatment side effects go away, like hair loss and diarrhea and whatever, but neuropathy, nerve damage, can stick around, as long as patients live. Next slide. So this is the primary endpoint. This is really comparing in a Kaplan-Meier, so-called Kaplan-Meier disease-free survival curve, 3 months versus 6 months. And you can see these curves are very much on top of each other. There's a dotted line at the 3-year mark, because this is where we have pretty solid data, because every single study that comprised the idea analysis had at least 3-year data for the majority of patients. And you can see 2 things. So first of all, the difference between outcomes in disease-free survival, meaning tumor recurrence or death, is very minimal between 3 months and 6 months. The trade-off at 3 years is minus 0.9%. That means less than 1 patient out of 100 in the overall analysis will have what we call a recurrence event, meaning have a recurrence compared to in the 3 month arm compared to 6 months arm. Now, when I talked about the statistical analysis, it shows that there's this yellow number 1.15, and I told you that the study would have been positive or met its pre-specified endpoint if this number was below 1 or not higher than 1.12, and this was not reached. So we were very ambitious in making sure that we're not harming patients by taking efficacy away, and for the overall patient population, statistically, this is not reached. Next slide. Now, when you have 12,800 patients, you have abilities to look at pre-specified and non-pre-specified analysis. In particular, what was striking us quite a bit was how different outcomes was between 2 separate groups of patients. One was the so-called, this slide is not formatted perfectly right. I don't know why that is, because it looked fine earlier. And it cuts off the lower part. But I think, the important point here is that when we look at patients which we consider low risk, that have not as advanced stage 3 cancers, not as much lymph nodes involved, tumors not that large, in terms of how much the tumor penetrates through the wall of the bowel, those patients have excellent outcomes. And 3 months versus 6 months duration of therapy, really the difference is 0.2%. So 2 out of 1,000 patients is the difference that they would experience a difference in this endpoint. So we feel very comfortable that in patients who have low-risk tumors, which make up 60% of patients, we would recommend 3 months duration of therapy and not 6 months. And this will make inroads into guidelines. This has changed the standard of care at Mayo Clinic. We're not treating patients with low-risk tumors for more than 3 months of treatment. Now, what's kind of cut off on this slide, which somehow got reformatted for this webcast, is the difference between FOLFOX and CAPOX, the 2 different chemotherapy regimens. I can just tell you that to our surprise, it appeared that a shorter duration of CAPOX was a great substitute for a longer duration, whereas FOLFOX, in particular in high-risk tumors, where you probably need more treatment, you really needed 6 months of treatment. For me personally, and we can't completely explain why that is, but I've personally looked at the data now for about 4 months, and I've come to the conclusion that we probably should be using CAPOX more, and then really we can talk about this in the discussion why and what the side effects would be and implications. But we have very solid data for 3 months of CAPOX compared to 6 months of CAPOX, and 3 months of this oral alternative where you don't need a port, don't need a pump, is clearly something that should be considered, at least something that patients should engage in their discussion with their physician. Next slide. So I hope that formats well. Okay, so that's great, because I think that's the most important slide, because it really shows us you know, what the consensus recommendation was. You have to keep in mind this was a clinical trials group of 20 experienced oncologists who have been in GI oncology, colorectal cancer treatment, and research for a long time. Actually, including the group that gave us FOLFOX as adjuvant therapy, the French group, and we had patient advocates involved and looked at the data for a long time with 7 statisticians involved, and our recommendation was very clear that patients with this low-risk group that I mentioned, T1, 2, 3, N1, so not more than 3 lymph nodes involved and small tumors, they should not receive more than 3 months of treatment. For patients who have so-called higher risk tumors, T4 and or N2, it's really where I think patients and physicians need to engage in a discussion. So the point is that at 3 months, I think really there should be a conference between patients and oncologists and say, how much more would we gain now if we continue the treatment? Because by that point, patients will have already seen, you know, what chemotherapy actually is. It's not easy to know what that really entails before you actually start treatment. But after 3 months of treatment, whether it's CAPOX or FOLFOX, I think patients know what a little bit neurotoxicity means, what fatigue means, what diarrhea can mean, etc., side effects of the treatment. And then it could be a discussion, should we continue the treatment or not? And this is really allowing us to engage patients in an educated discussion. And this is where I think, you know, patients need to talk to their oncologists actively. Next slide. So in the end, I just wanted to highlight the first part here. The IDEA data really provide a framework for discussions on risks and benefits of this individualized adjuvant therapy approach, where we believe, you know, this is where physicians and patients need to interact. Next slide. It's the final slide, which very important to me, because, you know, when you look at a question like shortening duration of a treatment, who would fund that? And when you talk about could there be commercial interest in having a shorter duration of treatment, of course not. These are questions that can only be answered by looking at federally funded, philanthropy-funded clinical trials, which we need exactly our taxpayer-funded dollars for when we look at NCI-funded research. This is what we would miss if we don't support federally funded research base, and I can only put a plug in for, you know, make noise. You know, we should not have cut in funding for clinically important research activities. Thank you.
Thank you so much, Dr. Grothe. Dr. Boland, you are up.
Okay, great. So, yeah, so thanks. That was a great presentation, and that's probably really the biggest take home from this meeting was that data. So to follow up this act, I was just going to present really some other findings that were brought to light. Some of them again, and then some of them newly so at this meeting, really with a focus on lifestyle, nutrition type interventions. So so vitamin D. So vitamin D, there's been interest in for a long time, and it's been said to potentially have benefits via a number of different mechanisms. So it's a fat-soluble vitamin, and in general, there's a few different forms in our body, but we tend to get vitamin D one of two ways. So it's via diet, food, or via our skin, so through sunlight. And it's pretty well established that there's links between low levels of vitamin D and thinning of the bones, and that giving vitamin D supplements can actually reduce risk of falls in certain groups of patients. And it's been from a number of lines of reasoning. There's been some thought that there may be some anti-cancer effect. So typically, so what is, and I've spoken this before, so so when we're thinking of vitamin D, do we have enough? Do we need more? So typically, the way we measure this is by this blood test, this total 25 hydroxyvitamin D, and there is consensus that a level of less than 20 is definitely deficient. I think some of the other things, there's between different groups, there may be slightly different agreements in terms of what appropriate levels are, but vitamin D deficiency is highly prevalent, particularly at the northern latitudes, where Mayo Clinic and Roswell Park are, and Boston. So at least by some groups, and this includes endocrinologists and some folks who are in this field, I thought that desirable levels are likely greater than 30. But again, there's a little disagreement. So by the Institute of Medicine, they've estimated that an average individual needs approximately 400 international units a day. And in general, by the IOM guidelines, really the upper limit has been set at around 4,000 international units per day. So this is a fat-soluble vitamin. So this is stored in the fat. If you take too much, you don't pee it out. So you can actually get overdosed in effect. Next slide. So so some large population-based and case studies basically showed that low levels of vitamin D were linked to a higher risk of colorectal cancer. And one highly relevant study was the Nurses' Health Study. This is a study that followed a series of women over a very prolonged time. And these were happened to be a very largely Caucasian population. So when you're looking at how does this apply to me? And so when they followed these women over time, they found that a number, almost 400, developed, in the cohort that was looked at here, developed colorectal cancers. And they had, in this group of individuals, they had vitamin D levels before the diagnosis of colon cancer. And they also had vitamin D levels of folks who didn't develop colon cancer. And so what they found is when they looked at vitamin D levels across the group, those that had, and they separated them into 5 different groups, based on like very low, low, medium, high, very high. The very high, the highest 20% versus the lowest 20%, there was 50% reduced odds of developing a colon cancer. And so that the vitamin D levels in the highest group, were quite high, and the lowest group, they were certainly in that deficient range. So this is consistent with these other, big studies. Next slide. So another, again, National Cancer Institute, essentially publicly funded study that looked at patients with stage 3 colon cancer, was this CALGB study. And this study incorporated in it a number of surveys and different tools to try to glean more information about lifestyle, dietary changes, and we've actually seen a bunch of very interesting things come from this. So this study had approximately 1,000 patients, and what they saw here was that when they looked at a predictive vitamin D score, so essentially vitamin D level, that this was linked to improved outcomes. So patients with good vitamin D levels in stage 3 did better in the long term in terms of cancer not coming back, being alive. Please go forward. Thanks. And so similarly to that, another one of these big same sorts of studies that looked at stage 4 colon cancer patients showed that the patients with the highest levels of vitamin D as compared to the patients with the lowest levels of vitamin D did also considerably better. So their survival was about 1/3 better, and the progression-free survival, or the time which they're alive and with control of the tumor, was also considerably better. So from these studies, at least the vitamin D level, when we followed it, seemed to link with how they did over time. Click. So there have been some efforts to look at, well, okay, if good vitamin D levels are good for me, what happens if I take vitamin D? And a lot of these studies, unfortunately, have been negative. As I said, for falls, we know there's some, in certain groups, there's some benefit for vitamin D. And so there's this Women's Health Initiative, this huge study that is an important study for some other reasons, too. They gave women essentially placebo or calcium and vitamin D. So this is the IOM recommended dose of vitamin D, or recommended daily intake, but a lower dose than we've used for some things. And they gave it to them on an ongoing basis. And so when they looked at 7 years, really they found between the women who didn't get vitamin D and calcium versus those who did, they found really no difference in the risk of colon cancer. So this was essentially a negative study saying taking vitamin D doesn't reduce your risk of getting a precancerous polyp, badness. But the concerns were, one, we tend to think that it takes many years, a decade to develop colon cancer. So is this length of treatment? Is this length of follow-up long enough? And then I would say at the same time too, is this dose adequate? And really, we don't know the answer to that. But suffice it to say that this is not used as a standard of care right now. Next slide. So, so the Sunshine study then was presented at this annual ASCO, and essentially this study was building on some of the things that I talked about, looking at, well, in early stage and in late stage colon cancer, good vitamin D levels are linked to better outcomes. So if we give individuals vitamin D, as well as standard therapy, will they do better? So what they did here, so this is a small to medium study. So this is not what I would call a definitive study. So this is all stage 4 patients, and these are all patients that were getting standard chemotherapy, and so everybody here got FOLFOX and Avastin, bevacizumab, and half of patients got, I believe it was half, got high dose vitamin D, and so they gave them essentially what amounted to like a loading dose for 2 weeks of this 8,000 units daily, and then they gave them really the upper end of what's recommended for an ongoing basis. And the other half got really the lower dose of vitamin D, what we saw in that polyp prevention study. And so really then what they looked at is what are the outcomes from this? Do we control the disease better? Is our responses better? Do patients live longer? Please click. So the results from this study were that there was in fact an improvement in the progression-free survival. So essentially disease control for these purposes, and it was modest, but it was there from a relative from a safe intervention. When they looked, is there more or better amounts of shrinkage? They really didn't see any difference. And when they looked at the side effects actually between the two groups, there was some suggestion that the rate of severe diarrhea was better with vitamin D. There was no they saw one kidney stone in the vitamin D group, but really there was no signs that this was harmful. So, so I think this is, this is not a definitive study. This isn't a study that says I need to go home, I need to do this, I need to tell my doctor I need to get this. But this is a study that suggested that, indeed there is possibly some benefit from vitamin D use. Certainly, it can be safely added to, with chemotherapy. But really, we would need to make the standard of care. I think a bigger study, or at least some confirmatory study to reproduce these sorts of results. I think at this point, this is not on guidelines for prevention of treatment, and I wouldn't expect it to be on guidelines. But I think it's certainly of interest when we're thinking about what can we do? How can I give myself the best odds? Next slide. So another presentation of interest really had to do with tree nuts in colorectal cancer. And so I'll admit I did not really know much about this coming into this meeting. And so what I have ascertained, I think during and since, is that so really there's the Mediterranean diet has been pretty consistently linked to improved health outcomes. So lower risk of heart disease, good changes in terms of cholesterol, and really when we look at the Mediterranean diet, it generally is hinged on a lot of things that we think of as we associate with being healthy, right? So high amounts of fruits and vegetables, cereals, nuts, olive oil, moderate intake of fish, white meats, moderate intake of alcohol, and then essentially low intake of red meats and processed meats. So, but as a component of the Mediterranean diet, nuts themselves have been thought to essentially have some chemopreventative and possibly anti-cancer effects. So this is these are things that have been seen when we look in petri dishes at cancer cells, and it's thought there's essentially some compounds in nuts and some healthy fats that may be of benefit. And at least in one big study in Europe, when they looked at dietary habits, they found an association of a high nut intake with decreased colon cancer in women. The same study didn't show the difference in men, so take that for what you will. Next slide. So essentially, this is again pulling on this big stage 3 colon cancer study, and they had about 2/3 of the folks who were on the study. Can you please click? And so on this study, basically, patients were asked to take questionnaires. So these are these annoying things where if you're on a study, you're sometimes asked to do additional paperwork. And so basically, patients did questionnaires during the chemotherapy for their stage 3 colon cancer, and then 6 months after chemotherapy. And among the list of questions was some questions about dietary patterns, and they looked at the total amount of nuts that patients reported. So patients reported how many nuts did they consume, or how many servings of nuts, how often. And it ranged really from never, I never have a serving of nuts, to I have a serving of nuts at least twice per week. And they also got information on what type of nuts. So tree nuts or peanuts. And so interestingly, when they looked at this data, really what we saw was that those patients who had the highest intake of nuts had a decrease in death of 60%, approximately 60%, and a decrease in the risk of a cancer coming back of approximately 40%. Next slide. Or I'm sorry, yeah. And so really, when they delved further into this and they looked at subgroups, they saw there was essentially a benefit for tree nuts, but not for peanuts. So tree nuts include amongst them almonds, cashews, hazelnuts, pecans, walnuts. So these are nuts with hard shells. And it's important to note that peanuts are really actually a different family altogether. Peanuts are legumes. So all these different nuts have different types of, I think, micro, macronutrients in them. And so it's not 100% clear from here, and I think we'd like to see more data on this, from other places. Which are the specific nuts that are better? Which parts of the nuts are actually helpful? What's the right amount of nuts, to get help? So I think right now, if you enjoy nuts, there's some suggestion there's a possible benefit from nut intake, but we don't really know what's the right amount that would help me. If you don't enjoy nuts, should you be forcing yourself to go out and buy expensive nuts? I don't think we're quite there, but I think, in the spectrum of what is everything I can do for myself to have, the best outcome, this is something where there's at least some evidence now. Next slide. So then the other thing is for us as medical oncologists, when you look at what are we supposed to be talking to patients about, right? And we, everybody's pressed for time, but I think, I like to think that we do a good job of trying to do these things regularly, or at least, after treatment for early stage cancer in particular. And so the things we think about really as being key are discussions and for patients to try to maintain a healthy body weight, as there's some evidence that's linked to better long-term outcomes, to get regular physical activity, so that at least a half hour on most days of the week by most of the consensus group discussions, and that can be brisk walking. To consume a healthy diet, which was an evidence on plant-based sources. To limit alcohol consumption, or alcohol in moderation at most, to avoid smoking, and then for certain patients to weigh the risks and benefits of something like a low-dose aspirin. So I think this is a decision to make with your doctor. This is not one where I'm not saying every patient should be on aspirin here. Next slide. So this is the same study they looked at on these two surveys. They asked patients questions about their diet, their physical activity, and their alcohol intake. And there's actually a pretty good amount of patients completing the surveys, which gives us better information, better data. And then they had to find some way to figure out what's good, what's bad. So they went and they scored the data. So they looked at your body mass index is normal, your body mass index is too high, and so patients got points if the things were the way we think they should be, right? So like not being overweight, getting regular activity, regular moderate physical activity most days of the week, and so they then compared essentially the individuals with the various scores. So you can see 0 and 1, so about a quarter of the patients had pretty low scores when they looked at these activity and nutrition attributes, and then a low percent had very high scores. So that's tough to attain. Next slide. And so interestingly, when they looked at this, does all these things we tell folks to do, are these things good in the long run, right? Do they improve outcomes? They saw really that and as you go up, doing more of the things we think you should be doing, there was a trend towards improved outcomes, improved long-term survival, and there was also a trend towards reduced risk of recurrence. And this became even more robust when they added in alcohol, moderate alcohol intake here. Next slide. So I should go. Yeah, thanks. So really, from here, the author's conclusions really were that colon cancer patients who had a healthy weight, who got regular physical exercise, who had a healthy diet, and limited their alcohol to moderate intake, that's 2 drinks per day at most for a man, and 1 drink per day at most for a woman, had a approximately 50% lower risk of death and approximately a third lower risk of recurrence compared to those who didn't do all those things. Next slide. So just a summary here. So really, just to sum up, from me, so vitamin D levels. So we have pretty consistent evidence that low levels are linked to worse outcomes, high risk of colon cancer. We have some additional evidence now that vitamin D supplements can be safely given, and that they don't seem to hurt with chemo. At this point in time, there's some suggestion that they might improve outcomes, but really I think this needs to be validated. This isn't something at all that I can say every patient who's getting chemotherapy should be getting high doses of vitamin D. I'm not personally doing this right now. We have some evidence that tree nuts improve outcomes, and so I think it's something to think about when you're looking at what are some things that I can do that fit into my lifestyle that might be good for me in the long term. And indeed, we have some evidence that really keeping your weight down, getting regular exercise, maintaining a heart healthy and I'd say a colon healthy diet actually improves your long-term outcomes. Yep, that's all for me.
Thank you so much, Dr. Boland. And thank you, Dr. Grothy. Really, thank you both for your presentations. It was much appreciated, very educational. To all our attendees, as a reminder, to submit your question, click on the small plus sign located next to the word questions on the right side of your screen and type your question and hit enter. We do have a couple of questions. So we'll get started on those. We do have one, we have a patient, John, who's been NED for 8 years following stage 3 rectal cancer. He's consistently tested around 20 in spite of taking 50,000 units once a week. Any thoughts on getting this up?
Sorry, you said 50,000 units of vitamin D once a week with a vitamin D level of about 20?
Consistently around 20, yes.
Okay. Yeah, I mean, it's, I think it's probably a discussion, and I'm sorry to cop out a little bit here. I think it's probably a discussion best to have with your doctor, and if there are ongoing concerns and there's reasons that you really, the vitamin D level needs to be better, you can discuss, is there a role, is there something else going on, that should be looked at.
Okay.
But yeah, I think it's difficult to say that you do like a higher dose than that right now. No, I don't think I can advise that.
Thank you. We have a question for Dr. Grothy about the IDEA collaboration study. Is the 3 months low risk versus 6 months high risk recommendation based on the assumption of the patient achieving cancer-free status at the end of chemo? What if the patient still has active disease after 3 months or 6 months?
So in these patients, they don't have active disease by definition because they're treating a cancer-free state prophylactically. So this is really a point where no cancer is visible in the body, and we're treating after surgery kind of as a, to reduce the risk of recurrence, but the cancer is not active in there. And there's, at this point in time, no means to see, to distinguish those patients from the reliable means to see where those patients who will have a recurrence, who won't have a recurrence. So there is no activity of the cancer, at 3 months compared to 6 months later. We just don't see the cancer anyway.
Okay, fantastic, great. All right, I'm looking at the other questions, and a lot of them may be more helpful for me to send to Dr. Grothy and Dr. Boland to look at. So what we'll be able to do is these will be sent. I have your name and email addresses, so people that have submitted questions will be able to get back to you individually, so that way you can get a better, more direct answer. Thank you, really, everyone, for your questions. It looks like we are, like I said, out of the questions. And the ones that are more detailed, I will send to the doctors directly.
Okay.
As a reminder to all attendees, you will receive a follow-up email tomorrow with a link to a very short, very, very short feedback survey about this webinar. We value your opinion, and I promise it should only take 2 to 3 minutes. Thank you in advance for your help. The information we gather from these surveys help us to build on our webinar series and help to put on even better webinars. Some of you may have questions you may want to ask in a more personal one-on-one setting. If you'd like to speak directly with one of our certified patient and family support navigators, please contact our helpline at 877-422-2030 or visit them online for a live chat at ccalliance.org. Again, thank you all for attending, and thank you, Dr. Grothe and Dr. Boland, for your wonderful presentations. We all hope you really enjoyed this webinar. As I mentioned, the webinar is recorded, and all registrants and attendees will receive a link to the recording. If you'd like to write to us, please feel free to forward more questions or comments to me at llefew@ccalliance.org. As you can see on your screen currently, you have a link to our webinars page. You have a link to our blog. In the coming weeks, we will have a blog in terms of the 5 best takeaways from this webinar, and there will also be a link to the webinar video as well, my email address, and again, the Colon Cancer Alliance helpline. On behalf of the entire Colon Cancer Alliance team, I'd like to thank everyone for attending this webinar. I hope you found it informative and value added. Have a great evening and take care. Thank you.
Great. Well, thanks, Lauren.
Absolutely. Thank you so much, Dr. Boland.
Have a good night.